Friends, it is possible to learn to operate with our non-dominant hands. This is a cataract with grade 2 nuclear sclerosis, and in this case I am trying to operate with my non-dominant left hand. This is the main incision with my left hand at around 2 o'clock, which is the easiest approach. I am sitting at the head end. So this is the main incision at 2 o'clock. And now some visco over the cornea, and then this is the side port on the right side of the main incision at around 11 o'clock. Now I am going to do Capsulorhexis. Puncture at the center, hold on side and do the rhexis here. With the left hand, I find that it is easier for me if I go clockwise, and with my right hand, when I do rhexis, it is easier for me to go anti-clockwise. So this is the and this is hydrodissection. Here is a fluid wave goes from one side to the other side. Very nice fluid wave has been seen. Some more mobilization, and the nucleus rotates. And now this is some more visco in the anterior chamber, and then I am going to take the pre-chopper. The tip length of the pre-chopper is 1.8, and this is the long pre-chopper that I designed recently. Tip length is 1.9, and see how beautiful is the crack. The right hand hooks the equator and divides the nucleus. Again, this is the other heminucleus. I could divide this also. So I have got 4 fragments by the pre-chopper and nucleus sustainer. And now the handpiece is introduced. The exposed part of the tip is about 1 millimeter or 1.5 millimeter. Because it is soft cataract, we don't need much ultrasonic energy, and the tip length is okay for this cataract. And now with my non-dominant hand, I am not getting as good fallibility as my right hand. Probably I have to practice some more days to get this trick which I have in my right hand. In right hand, when I operate the pieces come to the tip very easily. Here it is coming, it's not coming easily. But the antechamber is very stable, no surge, and in that way it is fine. It will take a little longer time, but cornea is nicely protected, no instrument touch on the back of the cornea, and I am always working at the iris plane, far away, and the tip is always at the center. It's not going to periphery most of the time. So the nucleus has been managed, and now I come out, inject some visco, not much visco, just some amount of visco, so that the antechamber is nicely maintained, the corneal endothelium is nicely protected. And now I am removing the cortex, going through the side port. Most of the cortex can be removed going through the side port. And now I go through the main port and remove the cortex. At this time also, the antechamber is nicely maintained and no instrument touch to the back of the cornea. This is hydropolish, taking by the irrigating probe of the bimanual IA, And now I'm going to do hydroimplantation by the left hand. Before that, I'm enlarging the main wound a little bit because I'm using a B cartridge. And here goes the irrigation maintains the anterior chamber and the intraocular lens is injected. This is being done by the non-dominant hand and the lens goes in the capsular bag. So it is possible to learn to operate with our non-dominant hands, and this may help in some situations. And we can do temporal phaco sitting at on place. For right eye temporal phaco, we operate with our right hand, and for left eye temporal phaco, we operate with our left hand. And we don't change position. You remain at the head end. Just for the right eye, we just go a little bit to the right side, and for the left eye, we go with our chair with wheel, we just go a little bit to the left side if we need to do a temporal phaco. And we can give exact incisions guided by corneal topography. Thank you very much for your attention. Hope this video will help you in developing your surgical skill. Please learn to operate with your non-dominant hands.